I gave an example this morning that in a particular location, I mean, in Liberia, the modeling study we are carrying out for the past 1 year show that female are more affected by Lassa fever than males. I don't know until now. I think the factor responsible may have to do with the fact that in Liberia, women are more into hunting than men. I mean, which is the reverse is the case in Nigeria. So, and then the age also play a role. There are certain health issues or diseases that more or less are age structured. Uh, they are more influenced by age. Take for instance malaria. You know, malaria affects certain age than the other age. Like take for instance children that are neonates under 5. There has been a mortality for several years before a lot of interventions started coming to play of children under 5 in Nigeria, and that was why there were a lot of other interventions that were put in place, like seasonal chemo prevention, and then I mean, and other ones. Recently, there was the perennial chemo prevention and all that, just to cater for children to build their immunity against malaria right from childhood. So if you are modeling malaria, one of the ways to also model malaria in terms of the heterogeneity is factoring age into what you are doing, and then you try to structure people from different ages. We also have a disease like female genital schistosomiasis that affects women mostly in Nigeria, and the disease evolves from certain age, you know, from age maybe age 0 to 15, and then if that person has the urinogenital schistosomiasis and is not being treated. But one thing about NTDs is that they are, when we continue our overview of infectious disease, we will see some of these things. So the way you model an NTD, that's neglected tropical disease, like schistosomiasis, like borreliosa, like trypanosomiasis, like um, bilharziasis, onchocerciasis, soil emitted transmits. Now, these are diseases of poverty, and then they are common in villages and local areas among the poor people, poor community, that doesn't have good water, access to good water, and all of that. And now, one thing about some such disease, they may not essentially cause mortality like immediately, but there is a lot of disability attached to most NTDs. Like a lot of people that have NTD, they have brain, I mean, there's issues with mental, there is a cognitive decline, you know. So most of them cannot have good assimilation because the warm body, depending on the level of the warm body. So now there's a way we model macroparasitic disease and then micro. I'm not going to talk about that one now because most of the disease we have been doing, mostly in Nigeria, they are microparasitic disease. And so for microparasitic disease, you are modeling the infection status. But for macro, which are large cells, like all these NTD, you are modeling the burden of the disease, the burden of the egg or the worms, because they are warm bodies. So now as you grow, because one thing about some of these things I mentioned, the NTDs, that as you grow in life and you don't treat them, the more the worms multiply. So you can go from low warm body to middle to and then to high warm body. And then when the more the worms in you and then the more the difficulties around your systems. Now, some of them, like the FGS, can also cause cervical cancer or female. So we have found that recently. The FGS paper we published on modeling was the first FGS modeling paper in Nigeria that will be looking at that problem, because we're given the problem by some set of parasitologists in Ogun State. Now, this disease evolves. There's an evolution from childhood to adolescent. So if the person is not treating it, if he doesn't treat it, and then you allow it to grow, the person can end up with FGS. And MGS, you have the likelihood of having cervical cancer. You have FGS. So, and that is why, we are beginning to look at some of these diseases and considering them, so that you don't just shy away from them. There are issues in Nigeria that people are confronted with. Now, for disease. So you can place them on different kind of demography. And then for place. Now you see, now when you are looking at disease from a local, in Nigeria we have about 772 local government. Not local government, polling units. You understand? 772 polling units. No, local government. 774 local government, but many more polling units. Many more. So 774 local governments. When you look at modeling from the data from local government level, you will see better things than when you are looking at the state level. You know the reason why? The state level data has become aggregated. That means they have collected all the data from the local government, they have collapsed it into one to form a state. But we saw that we were working on KB State at the time, because of the KB State happened to be the high burden state for malaria, and we had to go down to the local government. So we were considering we started with 3 local governments. We are still on that project, Arugungu and Alero, and one other local government like that. And it's a modeling that made me get familiar with many of the places. I've not been there, but I know many local governments in Nigeria now because of the data we are making use of. So many of the local government there. So you find out that when you model at municipality, that's at local government level, there are many things that you see, the underlying patterns of the data that becomes very close to the people like the local government people. Then when you are modeling at the state level, the data is already aggregated, so you cannot see what you'll be seeing at the local government level. Then at the country level, what it means that you are doing a kind of generalization that is very now is not seeing everybody. So, and that is why I really encourage, most times, either you are using state level data or local government level data, so that you are able to speak. At least if you are speaking at the state level, they can begin to look like what is going on within the state. It's very important. And then disease is also a function of time. It's not just location alone, time. Now, so data can come in form of week. That's weekly data, from daily to weekly, then from weekly to monthly data. The annual data is also like not showing many things. If it's annual, there are a lot of information that are lost. You understand? Because a lot of things have been aggregated, so you are not seeing the full dynamics. Now, assessing disease determinants, the web of causality, the complex interrelationship of numerous and indirect factors that interact to alter the risk of disease. So now there are a lot of things that come together, like we have been saying yesterday, since yesterday, that there are factors that influence disease spread. And one of them is that we're trying to look at is that apart from the climatic factors, there are the socioeconomic issues. Socioeconomic issues. Now, or the issue of, now that borders on malnutrition. You are giving somebody vaccine, but it's not eating well. The vaccine will not work. Let's be sincere with ourselves. You are taking ACT drug, you are drinking Gary. It's not going to work. I must be sincere with you. Yes, it's not going to work because you are malnourished. So the disease thrives in malnutrition. Yes. So now a lot of people, they are complaining of demons. It's not demons. You are malnutrition. But you don't have the right nutrients in your body. We have a nutritionist there. She can tell us many things about it. Emmanuel, am I right? If you have a good nutritional status, you can fight certain agents in your body and build your immunity. So if you don't eat well, you are taking ACT, you are drinking Gary, and then you want the ACT to work, it's not going to work. So you took vaccine, malaria vaccine or measles vaccine, and you are malnourished, it's not going to work. So those are factors that affect disease transmission, disease progression, and all that. You find out that some people are vaccinated, but the vaccination did not result in immunity. It's not, don't think that it's every vaccination that results in immunity. You can take vaccine and you don't end up with immunity, because immunity is an elusive thing. It depends on your system. Some people took COVID-19 vaccine, they had rashes and eczema instead of the thing building immunity in them. So now, what are the causal factors? We have disease agents. So what are disease agents we have? Disease agents. No. Disease agents. Not reservoirs. No. We are talking of malaria. Agents like microbial agents. No. Bacteria. Yes. Virus, yes. Protozoa. Hey, you are talking now. Fungi, yes. You have mentioned how many now? 4. Remaining 1. Helminths. Helminths and nematodes. Helminths are they are agents that affect, that brings up NTDs. Most of these NTDs, they are helminths, like soil transmitted helminths and all of that. So now for malaria, you have the protozoa. Malaria and most of the vector-borne diseases like dengue and dengue is viral. So, but some of the other vector-borne disease. Now, disease agents. Can we go back, sir? Disease agents. Now these disease agents, some are micro. What do I call it? Micro parasites. Some are macro. So the micro are the single cells, right? The macro are the large cells. So the macro, that is why you don't model macroparasitic disease modeling the way you model microparasitic. So we are going to talk about it, not in this class. It's not the same way. So the one we have been modeling, all malaria, Schisto is a macroparasitic disease. So you are going to model it in a different way. So in macroparasitic disease, we are modeling warm body, not infectious status. In macroparasitic disease, you are modeling infectious status. That's why you put people in different class: susceptible, infected, and recovered. But in macro, beyond that, you want to look at, we are not looking at infectious status, we are looking at the burden of the worm. And what are the 3 levels of the burden of the worm? We have the low, the medium, and then the what? The eye. So I won't say more than that now. I will still come back to that. So then under it, you have the climate influences. Climate, like we said, climate, temperature, climatic factors has a lot of effect. Like I gave some threshold yesterday. I don't want to go. Then human influences. What are those human influences? Human behavior. A drug can be effective. Some of us have tried it here. Even myself, I've tried it. I've done it before. They gave you a drug. After 3 days, you are okay. I'm fine, Gary. You stop using the drug, especially if the drug is bitter. No or yes? So you stop using the drug, but you forgot that you are dealing with the microbial agent. The guy is still there. He is only waiting for another time to build up, and then he will bounce back. So you didn't do complete treatment. Didn't complete your treatment. The person that gave you the drug and asked you to use it for certain days, he knows what he's doing scientifically, but you stopped. And then, so that's part of human behavior. Human behavior can also come in terms of misinformation. Don't take vaccine, oh. If you take vaccine, they will take your blood to one bank like that. In fact, someone said that all the people that took COVID-19 vaccine, they already, they call them one animal, Malu or something. I was like, that they are cows. I said, come on, when they send the message to me, they are cows. And the person that sent this message, the PhD holder. So I say, so you still follow this kind of thing? Oh, I'm ashamed. Do you know that someone this afternoon when we were going for break, somebody called somebody here and said, brother Steve, where are you? They said the whole of Benin has been blasted. They are bomb Benin. I say they are bomb Benin, but you are talking to me. Be careful on social media. He said they are bomb Benin. I said, but you are talking to me. I'm in Benin now. So how did you get me? If they are bomb this place, how will you be calling me now? You see social media. Be careful. And some of you just transfer the message to another person again. He's born, that place is, That's social media for you. So, human influences. That drug worked for me. When I use it, I slept without closing my eyes. And then you too. I need to be sleeping, when to use it. And you also want to sleep without closing your eyes. So you were there till the daybreak like this. Why? You didn't sleep any sleep. You don't know that there is a genetic factors that your own accepted, his own did not accept. So now, these are human influences that affect some of these treatment. So is it a root cause or could it be an antipath? So like in disease, like you see now, you find out that we're working on, that's why I question people, why do you do what you do? A lot of modelers are modeling stuffs, but you don't know why. Like somebody said he's doing co-infection. Why are you doing co-infection? How many of us have developed a model, co-infection model here? Let me see your hand. So co-infection on what? Tell me. Malaria and Zika virus. Wow, this man is a powerful man. Yeah, Prof. So
it wasn't my work.
Okay.
So I assisted PhD students doing simulation using Python to do simulation and optimal control. So I made the work already developed. No, it's not my work.
All right, no problem. I can't go further from there. But now, if I may ask you, what do you think? What's the reason behind that? Because, like, take for instance, in Nigeria, we don't have Zika virus. So, okay, there's somebody raising his hand. Okay, we are coming back to you, sir. So, why did you do malaria? Why do you think the person did malaria and Zika virus?
It is because they assume that in a setting where there is malaria already existing, as we have here now, assuming Zika virus is introduced, those who already have malaria are still susceptible to Zika virus.
Okay. Wahala dey o. So, okay, that you see now, you see the way mathematician thinks. He just sit in his office. Bring paper. Zika virus, assume. Malaria, assume. Boom. This one, marry them forcefully. Conduct wedding for them. Put ring in their hands. Send them for publication. The paper has been published, Abi. Okay. Thank you very much. Give us your own reason. I'm going somewhere. Oh.
I did my PhD work on COVID-19 and TB.
And TB.
Yes, sir.
The person will have died immediately. No. You are talking TB now. Don't go to asthma.
Yes.
Don't go to asthma.
So, well, we believe that from research, it has been shown that everyone in a exposed state has element of TB, but
No.
not in a infected
No.
stage.
You are not talking of. Okay. You said the person have TB. When you say it has TB, it means that it has been confirmed. Not talking of pre-infectious now. Confirmed case is different from suspected case. You know one thing about TB? It takes long time before you get to that confirmed state.
Yes.
And take like 10 to 15 years. Yes, you may have TB now. You are dancing around. But you don't know. If you don't check, you understand? You don't know. So, and then you just discover that at a certain time your immune system you are already showing the symptoms. At that time, that is a very complicated state. It's just like when you have malaria and it's severe malaria, the chances of dying is very high. Do you know why? Your organs, like the spleen, the kidney is already going. Yes, now. The liver is already chopped off. So, the large number of people who have severe malaria, they don't usually survive it. So, not to not talk of TB, by that time, your lung is no longer working well. So, when Mr. COVID now came, so it's a difficult thing. You see now, what I'm talking has been tested in the lab, and then there are cases of that. People who have TB, they just go to mortuary straight once COVID came.
Sorry, sir.
Yes, especially confirmed case. Yeah,
Confirmed cases,
yes.
because there is a latent stage.
Yeah, but you said the person already have TB. That was what you said. Have TB means that he has been diagnosed of TB. You understand? So if the person has been confirmed, then doing the modeling is a waste of time. Do you understand? Because there is no solution. You don't understand me now? Sit down. I will explain something. Now, we have malaria and schisto. And then we saw that by the biology, there's what we call the Th1 and Th2 response in the immune system. Th1. I don't know how many of you are doing biology, immunology. How many immunology do we have here? They are not here. Okay. So I hope you have heard of Th1 and Th2. Good. Clap for her. So what I'm saying is, now you find out that what made us to do, I did a work on co-infection. Now, you don't do co-infection because you just want to say, if somebody have malaria, they can have schistosomiasis. Oh, sorry, I can have what's it called, measles or something like that. You cannot sit down like that. Now, the biology must say something around it. Maybe there is an interaction. So if the biology does not establish interaction, then why are you bothering yourself, sir? So, like, the interaction means that maybe in the course of the treatment, take for instance now, if you have schisto, right? If you have schisto and then you have malaria, and you are trying to treat malaria first with ACT, it will not work. Yes. So the interaction of those TH1 and TH2 is affecting your immunity not to be able to fight. So now the biology says that when you use praziquantel, which is the treatment for schistosomiasis, then it brings malaria down. That's where our modeling came. So we are able to come up with a model that captures that dynamics. That's it. So, but if you don't see the biology, so sir, what are you modeling? Are you getting me now? That's why we are saying that now you must establish the biology before you, because we said that a mathematical model is what? Is a description of the real world in mathematical terms. So you need the real world. What is the real world saying before you start the modeling? So if you don't understand the real world, the concept of the real world, then your mathematics is a waste of time. So that's why you do this thing from the point of view of question, not from the point of view of I just want to model. Or you just sit and say, if somebody should have malaria, that means that it can have Zika. And then the person can also have HIV. And then the person can also have measles. And then you are having like 5 diseases on one person's body. And he's still alive. He's walking and eating gari. That must be a powerful man. So I think we need to, like what I said is that if you are bringing 2 diseases together, you must ask, what is their interaction? In what way are they interacting before you can say you are modeling co-infection? Now, so risk. This thing is not moving on. Okay. So risk, hazard, and vulnerability. Now, when you say hazard, you are saying hazards are threats that have potential to harm people and places. They are usually caused by the interaction between society and natural systems, like you have indicates, or between society and technology, chemical spills, or within society like civil conflict or communal crisis. Like in Nigeria, we have some hazards, like road accidents is an hazard. You know, even some of these diseases we are talking about, they are hazards. Communal crisis, they are hazards. Cholera is an hazard. They are all hazards. So because what are they doing? They are threats that have potential to harm people. COVID is an hazard and places. Why? Who is calling my? Am I the one? Okay. So they are hazards. So some of these diseases we have even CSM is an hazard. All these diseases they are hazard because they are harming people. They are destroying lives. You understand? Imagine somebody is just waking up and his neck turned 360 degrees. Yes, that's CSM. Go to the north, you see that kind of thing. They are influenced by temperature. Yes, when the temperature is very high, that's why some of you who are doing CSM, you should factor temperature as a dependent variable. As yeah, so something that you should maybe your transmission beta of T to be dependent on temperature, and then you factor, because we are working on climate here in this workshop. So vulnerability. Now, vulnerability also is an issue because a lot of people are vulnerable to the disease. You are vulnerable to certain disease due to many things, like the susceptibility of a given population, system, place to harm from exposure to the hazard, and directly affects to prepare for, to respond to, or recover from hazards and disaster. So you are vulnerable maybe due to your environment, due to where you are, your location, and then a lot of things make us to be vulnerable, or even your immune system. If you are malnourished, you will be vulnerable to certain disease, and then your recovery may not come fast. And then you have the risk. Risk is the probability that some type of injury or loss will result from the hazard event. So when you have an hazard, there are risks. Some things can happen due to the hazard. So what happened due to the hazard is the risk. So that's why we have risk is equal to hazard times the product of hazard and vulnerability. That's risk. So that means risk is a function of hazard and vulnerability. So disease risk waxes and wanes between population, geographical areas, and in time. So this variation is driven by environmental, social change. In the case of climate-sensitive diseases, variation in disease risk are also driven by climate variability on a seasonal, annual, interannual, or even decadal, that's 10 years time scale. Now, management of risk involves understanding variation and exploiting this to increase society resilience to impact. Now, hazards, like I mentioned, it's not just disease only. Road accidents, road traffic accident is hazard. Community conflicts, they are hazards, apart from diseases. Now, decision making for risk management. Should we intervene? Should we intervene? Then where should we intervene? Where should we start the intervention? That is the place. How much intervention is required? These are things that the decision makers are thinking about. Now, modeling can help us in this. What are the costs? What will it cost us? If you are deploying intervention in a particular location, can we afford it? That's what the decision makers are thinking about. Now they are thinking about how frequently should we deploy that intervention in that particular location. Is it once in a year? Is it twice in a year? If it is once in a year, what inform the ones? You don't just wake up and say, we'll start deploying intervention from January. And then people, if I'm a sensible person, I will ask you why. You know, like I'm questioning a lot of policy in Nigeria, and every day I keep questioning. You know, when I was coming, I was looking at the bridge. They were constructing one bridge in Boko, and I'm trying to look what's the population of Boko people. That money would have been used for something good, like education. All those people who are suffering, who are in IDP camp, they build houses for them. Give a LLIN nets for mosquitoes not to hit them and all that. To take care of the environment. So when I was looking, I was thinking that maybe I need to find out the population of Boko, and then I will be able to know whether there is a hold up or anything. I've not seen. When I was coming, at least I didn't see any hold up. So I was asking, what is the need for that bridge over? I saw one bridge. I think they were still constructing it. So the question is that, you see, policy now, people don't know what to do. Clap for her, clap for her. She's already been infected. Okay, so what tools should we use for monitoring progress? We need to ask that. These are questions. How will we measure the success of the program? So these are things that the decision makers want to know. And these are questions that if you are doing modeling, you can look at. Should we send, I'm checking. I'm in tune. So lastly, I want to quickly look at this. Why is it shaking? I'm only seeing myself. Oh. So measuring disease or public health outcome. So we are looking at incidence. So what is incidence? Who's going to tell me? What's incidence? I'm rounding up this session now. Yes? Tell us your name and your account number. Okay, from where?
Enugu State.
Enugu, from Uzowade.
Sorry.
Isi Kano West. Where are you from?
From Price.
No. There's a local government called Price in
No,
Enugu.
no. Okay, I'm from Enugu State, Ogun, local government.
Ogun, that's
Yes.
Okay, tell us.
Okay, incidence is the number of
Huh?
one 1 8.
Don't worry, she will see me after. Don't worry.
Incidence is the number of newly infected cases in a population
You have not finished.
over time.
Good. Yeah, because it's a time evolving thing. Yeah, thank you. What is prevalence?
Prevalence is the total number of cases,
Which cases?
existing cases in the population over time.
Both old and new.
Yes.
Clap for her. You see, if you don't know all these things and you just enter modeling, you will just be confused. That's how you go and model wrongly. We need the biology. So some of us who are mathematicians, you better write those things down now. Write them down your notes so that when you are doing prevalence, you know what you are talking about. You see what she's saying. So that's why we need multidisciplinary. She's coming from which area? Parasitology. So you sit down in your office, you are developing model, and then you didn't factor some of these things. You are going to be doing theoretical stuff. Yes? I have 40 seconds more. And you have refused to show me my slide. Okay, so now we have incidence measure. Now under incidence measure, I'm going to talk about this and then I'll stop. Incidence rates. Incidence rates. So what is incidence rates? Now, and what is cumulative incidence? Incidence rate is when you have incidence and then you divide it by the total population. That you have rates. Are you getting me now? You are dividing your incidence with the total population. You are talking of rate. Now, when you say incidence, cumulative incidence, you are talking of, you are adding up incidence. Now, the first day maybe the first day you had 1, the second day you had 2. So if you want to say like 1, 2, 3, 4, 5, up to 10, right? So if you want to say incidence and cumulative incidence, you are saying the first day is 1, the second day will be 1 plus 2 is what? 3. Then the third day will be 3 plus what? 3, which is 6. The fourth day, so you are adding just like OGIV, right? In your secondary school something. So and then everything will now be what? A straight line. So you cannot use cumulative incidence to fit a model. Do you know why? Because if you get a data from HIV, let's say HIV data, and it's cumulative, and you have a cholera data, and it's cumulative, everything will be a straight line. Do you understand me now? So there is no information that one wants to give you. Everything will be the same. You get me now? To be like F or something. But if it is incidence data, it will be like a wave, like what we did yesterday. And then you can see seasonality, you can see cyclical patterns, you you can see the trends and all of that. Thank you very much. I'll stop here.